Good morning, welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 26. We have another very interesting, a genuinely complex case, and without any delays, let me take you to the cardiac cath lab where Dr. Kini and Dr. Sharma are standing by. Good morning, Samin.
Morning, sorry for a few minutes late start, but we are all set now, and hope this is our 12th the case with the heart.org and Medscape.
Exactly
and,
right. It's the first anniversary today.
First anniversary with them, and of course, on the chronologically, this becomes our 26th case so far. This will be the 26th case, and I welcome all of our viewers, and really thankful to you. You're doing a tremendous job during these cases, keeping all the questions and making the salient points, and we keep hearing on the webcast and the feedback from our audience, what they need to improve and so. And that's one thing which actually has come up quite a bit, that when they see it back our archives, that the pictures, the cine pictures are very small on the screen, and we are in a process of making whether we can make some changes so that when it is re-reviewed later on, it can occupy the entire screen. But I think that will require a little more of audio visual and feed, but I'm sure those things could be done in this day and age of advanced technology.
Samin, you are also, I understand, going to be addressing the very important issue of staging of PCI today.
Yes, that actually is clearly with the recent papers in JACC, two of them with editorial, and so it has come to really limelight, and I felt that we always try to bring our audience and every interventionalist to the latest what is going on, keep them updated with the latest advances, and we change our practice, and that is will be the goal also to address that issue today. So with that note, let me quickly start because we are ready for the case. I know we are a little delay, but we should still be able to finish it just peri 9 a.m., maybe 5 minutes or extra. That basically this is the patient. We can show the slide of yes. This is the patient presented actually a few weeks ago with crescendo angina, the angina class 2, and has a stress echo, both anterior and inferior wall motion abnormality, and cath revealed 2 vessel disease and minimal LV dysfunction. He had basically stents in the RCA, stent in the LAD. LAD stent was the Taxus stent, and RCA was the was the cipher stents in the past. And what we did is, because of the significant lesion in the proximal LAD, did an AngioSculpt, balloon angioplasty, high pressure, followed by XIENCE V, and patient did fine. As you can see, medical history significant for the PCI and risk factors, and good medical therapy which this patient has been. And of course, after the PCI, we started this patient on Clopidogrel, and that could be the question, that should be the right approach, or should we change these antiplatelet therapy to some new which we actually have at present. Now basically, just to say again, these are the lesions, and actually RCA will show a little more, and patient has syntax score of 21. And today at discussion, maybe Anu can show this from the angiogram, maybe just after I finish the appropriateness point of view, that basically this patient has 2 vessel disease with the intermediate risk scan and class 2 symptoms, so that's appropriate from the PCI point of view. Anu, you want to take us through the angiogram?
Yeah. So you see the left main non-obstructive, the LAD PCI site looks okay. Distal, actually there's a lot of disease in the apical LAD, and the circ majority of it non-obstructive, OM is okay, but the diffuse disease of a small size LPL. And this is the LV gram.
Anu, the diagonal looked exactly the same way before,
yes.
A little nicking of the ostium.
Ostium, that was there even in the last angiogram. And here is LV, actually anterolateral still hypo, apex is okay, and infrabase is still hypo, and this is his RCA. If you see, he has had prior PCI, so just took up, since we don't have the old angiogram to see how exactly the stents were placed, we took a cine run to see how the distal RCA stents look like if you see there, we could just make a assumption probably they did a reverse T technique into the PDA. There is a stent in the RPL and the proximal RCA stent. So, this is how the angiogram looks. So, the proximal RCA stent looks okay. Then after the RV branch is a significant looks like angiographically mild calcium, but significant disease there. Distal RCA is okay, but what we are looking is the disease at the bifurcation into the PDA also, and then RPL actually beginning of the stent and the distal edge of the stent, and RPL2 AV continuation and RPL2 what we are talking about disease in the distal vasculature.
Okay. Now you want to quickly run the IVUS. We are done in this.
Yeah. Let's show the IVUS.
Show the IVUS. We can screen to the IVUS, please. Oh, they have it. Okay. So if they can show it from the good. Yeah.
So just with the initial angiogram, the question always comes in this kind of situation that how we were going to handle this case, that there is mild to moderate calcium in the mid RCA level. The more important thing is, do we just take care of that mid RCA disease and leave all the distal disease for medical therapy, versus we take care of one of the branches at the level of the bifurcation, more importantly maybe the PDA versus the RPL. For that, very important is to know exactly how that distal RCA stenting technique was done. So just by wiring we could go into both the branches, but that does not mean getting device into this particular area could be easy. And just if you can see the IVUS that is playing, this is the proximal portion of the RCA stent. Just go back to where the title yeah, that is where I think you see what we saw angiographically also was probably mild calcium, but a lot of plaque at that particular area, but there was some moderate to severe calcium distal to the lesion. Go to B1, at the level of the B1.
Yeah, I mean that's the important point, because we understand the rotational atherectomy reserved for a heavily calcific lesions if there is a more than 3/4 arc of calcium, but here looks like at the lesion there is not much calcium.
Not at the level of the lesion, but
we need to see. But look at the proximal stent. You know, this is, we know the proximal is cipher, and which is typical. We have seen very little intimal hyperplasia, so nicely open. The distal stents information we do not have exactly what those stents are. We know that left sided was a Taxus stent which re-stenosed, so that and this is, look at the very great arc of calcium.
Calcium at the level just before the lesion starts.
So Sameen, in one single case you are summarizing the results of the COMPARE trial.
Yes.
Here.
Yeah, the incredible. Yeah, absolutely. I mean, this clearly the question basically has come that the paclitaxel coated stent definitely had a higher restenosis, as we know, particularly in the more complex cases, and now compared to the everolimus. And here is the nice example of the sirolimus eluting stent. Now, Anu, you want to go through your quickly points, and then I'll go with the theory while you will be wiring this.
I mean, you go ahead with your presentation, and we'll.
Good.
Okay.
Okay, Anu, here we go. Anu, back with you. Here is your slide.
Yeah, if you can see, I think always when we are doing this kind of cases, question comes is guide support. In this particular RCA, since the way the RCA take off, and you already know there is no disease in the proximal RCA, we just went with the what we call as a benign guide, which is our favorite for the RCA, which would be Lima. Now the question always comes is, whenever you are dealing with the bifurcation disease, and we know patient does not have peripheral vascular disease, I think it's always better you go with the 7 French if you have the leeway. So we do have a 7 French Lima guide with the side holes in this particular case, and we have dealt with how to deal with the calcium, where we felt there is at least moderate calcium in the mid to distal RCA, that maybe it is better we take care of the with the rotational atherectomy. In this particular case, question always comes that how if you are doing rotational atherectomy, how do you get, how are you going to get decide on the burr size? Always this depends on the vessel, the lesion severity, and if there is any angle at the lesion. If you see here, the lesion itself is not angulated, short lesion. So, in that kind of a situation, I think though this RCA is between 3.5 to 4.0 vessel, severity almost 90% disease, that 175 burr is what we have selected for the mid RCA. For the distal RCA, where you have bifurcation, and now we are dealing that you will have to go through the stent strut into the PDA, there we will always is 1.75 burr the right size versus 1.5 burr we need it, depending on how we are going to see the rota burr how it behaves. We may have to downsize, but important I think technical aspect here would be doing the mid RCA rotational atherectomy would be easy, but more difficult is how we are going to do the rotational atherectomy through the stent struts into the PDA, that we will have to do the dynaglide, and doing dynaglide means you have to bring the burr from the mid RCA to distal RCA will be a special dyna technique. So, there technical aspect will be how your burr pull push have to be done, which we will show how exactly you will bring the burr to that particular area. And the last point was that how do we take care of this bifurcation disease. Always the goal is take care of one important branch, and here I think we will focus on the PDA, the other one we just going to do PTCA. So, that branch will remain open.
Good, very good. Now, I think if we can go back to this fluoro again and little bit of discrepancy. If you can see there exactly around 7 o'clock, see the chunk of calcium actually like 8:30 area, and the lesion is little proximal to it. See that, I mean that is a very, I felt that will be angiographically clearly we decide based on the angiogram whether to decide rotablation or not, and based on the angiogram we decided. Now question comes, knowing that the lesion itself is not calcified, but the process around the lesion proximal and distal is still very calcified. So, that should the rotational atherectomy be done. I can tell you as the biggest proponent of rotational atherectomy, if somebody wants to just do a high pressure balloon dilatation and or maybe AngioSculpt or cutting balloon and then put a stent is completely fine. Therefore, we just try to see how maybe we can take some poll and people can give the opinion what they will do in this particular situation. Just because of the calcium, we felt that we will go ahead and use the rotational atherectomy. Now, with that note, what Annu will do meanwhile is trying to put a rota wire, and usually these complex long cases, it is always better to use a fine cross and using a fielder wire or run through and then change it to the rota wire. Although rota wire can go directly also in this case.
Anu, yeah. Great choice of the Lima guide. I was wondering why did you need side holes there?
Yeah. Huh?
I think the Lima guide is a very good choice. I am not so sure about the need of side holes.
Yeah. Well, I mean the very important, I will tell you what the reason is. We use quite a bit of side hole because we have seen many times when these guides sit there cause lot of spasm, and we just routinely in our the practice, I mean particularly if there is a 7 French and so try to use, the only reason will not use the side holes if there is a issue about the high contrast, knowing that some of the contrast you waste.
Yeah, which is exactly what my point was.
Yeah, absolutely.
Samin, take us through what you have in mind, and I believe you are going to cover the very critical important issue of staging.
Yes, clearly that if we can go back to the slides now, and again we try to make, you continue your rota wire.
I wanted to show a point.
Okay, now before we go on, we can go to fluoro again, 1 second. Okay. Yes,
okay, so what is happening is I am trying to wire at this distal bifurcation is the same thing. Very important is why important that you go with your workhorse wire, and more important whenever you are going through instant restenosis or bifurcation, better to have a fielder or any kind of a glide coated wire, so that you are in the true lumen and not going through stent struts and going back into the lumen through the stent strut. So, if you see here the way the wire is behaving, if you can see that it is not an easy pass at the level of the bifurcation.
Probably needs a little more shape also.
Yeah. So, in that situation is what your tactile feel is telling you, is the wire movement very easy or no. If not, you come back and keep wiring till you know the movement of the wire, and now that the fine cross
Samin, in the meantime, you
movement is
can
okay.
answer a question which has come by. For the LAD, you used AngioSculpt for the instant restenosis. Is that something you're doing very commonly?
Yeah, I mean the reason is either AngioSculpt or a cutting balloon. The reason, the logic behind there is that many times they require high pressure for this intimal hyperplasia. Many times stents are region restenosis is the focal, the unexpanded stent. So you need a high pressure or debulking. Now the data basically are that what is the difference in high pressure PTCA versus atherectomy of the cutting balloon or AngioSculpt, and the answer is very simple. Basically, it just gives you a little better lumen, but more importantly, less slippage, so that now you can have a better stent expansion, cause less dissection. Now, if your plan is to do restenting, then I don't know whether you really need this additional expensive $800 gizmo of whatever the cost is, $650 to $800 of the cutting balloon or AngioSculpt. But in those cases, just to go to a very high pressure and restent. And clearly that the both everolimus as well as paclitaxial coating stent has been approved for instant restenosis of the bare metal stent now.
But you would not use the rotablator in those cases?
Yeah, rotablation actually based on the ARTIST trial, although our data did show initially a little better results in the roster, but overall the reason to use rotation atherectomy would be if you see a visually unexpanded stent or there are multiple branches. Those are the cases we'll use a rotation atherectomy. In the otherwise the rotablation just for a routine ISR has gone out of the favor, and we also don't use it in our practice at this time.
Wonderful. Another very quick question which has come: when was the last time you used radiation for instant restenosis?
Yeah, very good point. Actually, I was told that only one center doing radiation brachytherapy at present, which is Washington Hospital Center with Dr. Waxman. And if some cases had to be sent, I sent one case around 3 years ago. Since then, yes, and then the data on the DES ISR, knowing that first now we can use various combination of the drug coating before declaring patient a failure of DES, because if you are sirolimus, everolimus followed by paclitaxel, and therefore rarely they will require, and of course some of these cases even go for radiate brachytherapy may have a higher event rate. And the patient who had actually brachytherapy one time came back, and therefore really, as I said, that in 3 years we have sent one case 3 years ago. Since then I have not sent any patient for brachytherapy yet.
Another quick question which has come: if you had a drug coated balloon, would you use it here?
Yeah, I would say it makes sense. It definitely makes perfect sense of the drug coated balloon based on the available data, but the problem is if you are comparing it against the balloon angioplasty. Now question comes is that regular balloon versus drug coated balloon. Yes, drug coated balloon will win, but will the drug coated balloon will be better than the drug-eluting stent? Another drug-eluting stent still need to be seen, and there is no clear-cut answer on that point. And there are some data on the PAPCAT studies have shown that maybe the DES is still better in those cases. So that drug coated balloon, if you are not planning to do another DES, is a very reasonable alternative. And knowing that the DES is not available in the drug coated balloon, not available in United States right now, they just have started the trials of Lutronics in the peripheries, and of course ultimately it will go down to coronaries later on. Now with that note, while let me just quickly in next 10-12 minutes go through this process of while we are going to get the rotablation ready about these two important points: the newer antiplatelet therapy for acute coronary syndrome and PCI, and the second is, as you said, stage PCI in multi-vessel CAD. The one by one, basically this is a very nice diagram from European Heart Journal by Dr. Angiolio, basically showing the various potential mechanism for platelet activation and inhibitors which are present as well as in the future. Now we are very well aware of the thromboxane, we are very well aware of the ADP receptor blockers, but there are many other receptors which stimulate the platelets, and they are on the platelet surface, and which actually now are the focus of subsequent investigation, which is basically the PAR1 antagonist, which is the thrombin receptor blockers, and the adhesion the 5-HT2A antagonist, and besides various the newer thromboxane A2 inhibitors which are coming in the market. So, I am going to go through all of these, that what we have at present, what the future holds for, and these are various the mechanism of the antiplatelet therapy which works at various levels, including the anticoagulants which are coming also in the treatment of acute coronary syndrome, and I will show you the data where we are, and this is a very nice schematic picture to show where various drugs work. So, basically this is a slide which puts all older and newer antiplatelet therapy with the ticlopidine, clopidogrel and prasugrel already available, Ticagrelor with the champion trials showing that it is no longer being investigated at present. Some bridge therapy will be starting soon for the patient who are going for bypass surgery, but the agents wise we have now clopidogrel, prasugrel, and recent approval just few weeks ago of the Ticagrelor. Last month with the available by Brillianta, which is a different not a thienopyridine, it is a separate CP T inhibitor, and it is oral, it is a twice a day drug, very the rapid onset, reversible, and time to peak takes about 2 hours. And there are 2 other agents which are in the trials at present, which is the Elenogrel, which still do not have the class what it will be, but available oral and IV. Only antiplatelet therapy which is available as IV and oral. So, you give IV at the time of the PCI immediate action, and then you substitute with the oral. And the lastly is this thrombin receptor antagonist which is the sharing and Vorapaxar and various other agent of the PAR1 antagonist which are being used. These are the reversible, as you can see that we used to be irreversible the inhibition of the platelet. Now, we are going to more of a reversibility. Reason is we know antiplatelet therapy works well, but the being irreversible cause more bleeding. That can we offset that is the bleeding issue by bringing the reversible antiplatelet therapy, and that is where the market is and the science is going, that we are trying to look for a more of a reversible antiplatelet therapy rather than the irreversible, which we know they work very well just like clopidogrel and prasugrel, but at a price of having a bleeding. Now, this is just to say that no matter what we say, that comparing the clopidogrel versus prasugrel from the TRITON-TIMI 38 trial, that if you see that if you make with a VASP the 50% inhibition is the cutoff, that some patients, yes, the less number of patients with the prasugrel, more with clopidogrel will be more than less than 50% inhibited. So, that PRI is more than 50% in some percent of cases, and it seems to be that this actually has come to the limelight at present, that even with any antiplatelet therapy, if you are not inhibiting the platelets adequately, they will have a follow-up event. And this is the latest paper after of the prasugrel just published in JACC, showing that 25% of the patients on the given dose of prasugrel with a 60 milligram load and 10 milligram maintenance did not get the VASP index of more than less than 50%. So, 25% of these patients did not get the 50% or less inhibition, and what is the price that basically associated with, which is called the column of the HTPR, high treatment platelet reactivity, have a higher MACE rate. So, that clearly seems to be the inhibition of the platelet. We need to get whether it is a clopidogrel, prasugrel, Ticagrelor, more effective dependable inhibition is the one which is going to decrease the overall event, and of course, you are very aware of the data of the TRITON basically with the prasugrel and clopidogrel. Now, then the new agent which is the Ticagrelor has been shown, as you can see here, a very rapid onset, that within 2 hours, 1 to 2 hours you got the 80% inhibition. Compared to placebo or clopidogrel after the loading dose of 180 milligram compared against 600. So, that we have another agent now which is dependable, just like if you make it the prasugrel curve will probably follow the exactly of the Ticagrelor shown in this slide, and this is exactly we have shown it in the past. Also very important is the same, is it the drug metabolism or it is the patient's own the genetic mechanism, and this is the RESPOND study which basically saw that if you see the red being the Ticagrelor and the green being the clopidogrel, and the patient were their own control, the crossover on the left side the prasugrel patient, the Ticagrelor patient got the clopidogrel and vice versa, and you can see the red consistently inhibition which we achieved by Ticagrelor. So that seems to be very effective. Now this slide is actually very important, and this is where goes back to also our recommendation, that despite we say the rapid we know the rapid onset as shown on the left of, but if you go to the offset on the right side, the lower curve is the Clopidogrel and then the Ticagrelor, that it takes about 3 to 5 days for the inhibitory effect to go down to less than 20%. Why that is important? Because if patient goes for surgery. Although in the trial it was mentioned that you can stop the drug 3 doses and patient can go for surgery, but nobody was comfortable. So the overall FDA recommendation still is that even with Ticagrelor it will take you 5 days, so that compared to 7 days with prasugrel, 5 days for Clopidogrel and Ticagrelor before patient going for surgery. Although the trial involved skipping 3 doses, but very rarely patient went to surgery in less than 5 days, so that FDA did not make a recommendation that you can send patient after Ticagrelor stoppage within 2 days. It's still a 5 days, and this goes back to this very important slide on the right side, where the offset takes about 5 days to bring it down to less than 20% inhibition. And this of course was approval based on the Plato trial, which was trial of acute coronary syndrome incorporating PCI, and PCI was done in 2/3 of these patients, and it was a 2% reduction in the death, MI and stroke. And very important issue remain is the death. Now although the combined endpoint was about 2% reduced in Ticagrelor, but look at the cardiovascular death as the primary endpoint as well as the secondary endpoint. Primary endpoint was a one event and the secondary endpoint as a cumulative, that clearly there was a statistically lower mortality. Besides having a lower myocardial infarction, statistically lower mortality in the Ticagrelor group, although there was a slightly higher non-fatal stroke, but non-significant. But more important point remain is that the Ticagrelor group had a lower, statistically lower mortality and non-fatal MI. Now then question comes, does it come at the cost of bleeding? We learned that we have similar effect with the prasugrel, but that was associated with a higher bleeding rate. In the Plato trial, you can see here, I'm going to show you a few of the bleeding slides that shows that the Ticagrelor, despite very effective, despite lowering the myocardial infarction and the decreasing mortality, was just a slightly higher bleeding compared to Clopidogrel, and particularly our life-threatening and fatal bleeding was not high. And that's a very important message. Remember in the prasugrel trial it was 0.3 versus 0.1, 0.3 for prasugrel versus 0.1 for Clopidogrel. There was 0.2% higher fatal bleeding. So the 1 in 500 patients will die with the use because of the fatal. But clearly the fatal bleeding in the Plato trial was not significantly higher with the Ticagrelor versus Clopidogrel. You say why? Very simple, reversible and short acting of the 12 hours is the issue. And now these are the various, if you just take the patients on various cut points, as you can see that yes, there are some higher bleeding, but the major fatal life-threatening bleeding was not different. Now also if you just take a non-cabbage related bleed, there is some trend towards a higher bleeding, but again it did not make a statistical significance. More importantly for us as an interventionalist, are we going to use the drug in our PCI? And this is the 2/3 of these 18,000 patients, which is about 13,000, got the PCI. And these are the data on the Ticagrelor patient versus Clopidogrel. Clearly significant benefit of death, MI and stroke, lower cardiovascular death, lower definite and probable stent thrombosis. So that's similar data what we have prasugrel also we found with the Ticagrelor, and this is the invasive strategy follow up at 1 year. And every group, whether it was the complex case or the patient with the diabetes, age, sex, the curve remains on the left side in favor of Ticagrelor. Bleeding still remain the same, the slightly higher, but not statistically significant. In some cases yes, so that we need to be careful with the bleeding, particularly non-cabbage bleeding. We need to be very clear that any drug, any antiplatelet therapy will cause bleeding, but the Ticagrelor comes to a lower mark in that causing higher bleeding. One of the big issue which actually is, has been talked about is the higher incidence of dyspnea. And remember, it's a AD because of the decreased uptake of adenosine to the RBCs. There is a higher adenosine level, and just like what we do when we do a pharmacological adenosine stress test, patient feel dyspnea. So because of that, patient very high incidence of dyspnea, but they found it did not cause any change in pulmonary function test. and the drug was not highly discontinued just because of dyspnea. But in the real life, it will make it a matter very difficult that what happens, patient complains of dyspnea 3-4 days later, what you do, you are worried about stent thrombosis and so on and so forth. So this, how will it pan out in our clinical life, we need to see. Then of course there was some bradycardia, some ventricular pauses, again not significant, slightly higher increase in uric acid and serum creatinine. One of the biggest issue which withheld this drug for approval was its non-effectiveness in the North American group. What does that mean? You see here that only of the 18,000 patients, less than 10% were done in US. But in the US, if you can see, the primary endpoint was 12.6% versus 10.1 in the Clopidogrel group. Basically showing that there was no benefit in US patients enrolled which were less than 10% in the trial, like 7 or 8%. You say, how can that happen? Well, they actually looked into various theory and hypotheses, and turns out to be very simple, and it leads to the interaction with the aspirin dose. I mean, it's hard to believe, but that seems to be the only difference, that in the US patient, if you can see here, once you use a low aspirin dose, less than 100, you still have favor with the Ticagrelor. But if you use a high aspirin dose, which is 300 milligram, the benefit was washed out, rather it is a curve come to the right side, that Clopidogrel. So that recommendation has been that if you are using Ticagrelor, use a low dose aspirin. In Mount Sinai cath lab, we are using 81 milligram anyway. So that, but just to be very careful that once you decide to use Ticagrelor, has to be done with the 81 milligram aspirin. So now I have put this comparison of the Plato and Triton trial in various perspective, and you can see that the both drugs are quite effective, but very important, the mortality reduction, significant mortality reduction comes with the Plato with using a Ticagrelor, although prasugrel did have a little trend, but was not statistically significant. So now basically all the drugs will be available. What would you use by year end? That's what I say. This is my personal point, the viewpoint which I published last year in December. The prasugrel is available, usual dose is 60 milligram loading, and then you give 5 to 10 milligram PO daily for 12 to 15 months, and 5 milligram we are favoring more because of the bleeding compared to 10. Ticagrelor is 180 milligram loading dose and 90 milligram BID for 1 year. This is the negative point, BID dose, but that's what the drug is. That's what the benefit of the drug is, lower bleeding. Then the Clopidogrel is the 600 milligram loading, and now some people use 150 milligram based on the OASIS 7, used to 1 to 4 weeks, and then of course you go down to 75 milligram daily for 1 year or so. Now basically where would you use when all are available? I would say prasugrel, STEMI patients, multivessel diabetics, and patients who are allergic to Clopidogrel and non-responder, very good data to support that. Ticagrelor, very important, patients where you don't have coronary anatomy, patients with acute coronary syndrome. In acute coronary syndrome, we don't use prasugrel in the ER, but Ticagrelor could be the drug. Patients are transported, they use coming to the cath lab, you don't know the coronary anatomy, patient need to go for surgery, so that Ticagrelor will be a better drug, where the CABG could be and you don't know the coronary anatomy. Also there are data for the Clopidogrel non-responder do very well with the Ticagrelor. Clopidogrel, very simple, patients with lung, renal disease, anywhere we know that it has caused less bleeding, so that all patients who are doing well on Clopidogrel, lower bleeding, to me will continue on Clopidogrel, and that will become important because getting generic within few months, so that the cost difference sometimes will drive our decision making in interventional cardiology. And I think that all will have their set, about one third will be available. Now then, just to very briefly, the two new drugs you will be hearing quite a bit. One is the Elanogrel trials, which are the ERASE-MI and INNOVATE-PCI phase 2, completed phase 3 being planned, and the second group is the thrombin receptor antagonist trials, which are Vorapaxar with the TRACER trial and TRAP2P trial, which is basically working on the thrombin induced platelet aggregation and has no effect on collagen induced platelet aggregation. It basically means you reduce the thrombotic event, you don't reduce and you don't cause the bleeding, because that collagen mediated closure of the vasculature continues. So that this is a very important, and this is the INNOVATE-PCI trial design, which I have shown here, which is starting the randomized trial, and these are the Vorapaxar TRAP programs with the two of them coming in the future. Now there is a lot of buzz about the direct oral anticoagulants, newer dabigatran and rivaroxaban and apixaban, the various trials which have been shown, but as you can see that overall what we learned from these trials that they cause more bleeding, and therefore this is the classical example being appraised 2, that not much effectiveness, higher bleeding, because they were added on aspirin and clopidogrel therapy. So that I sum it up, the newer anticoagulants in the ACS that added to DAPT is associated with dose dependent higher bleeding and minimal or no added ischemic benefit, so that probably will not be beneficial in the future. Now, second issue quickly, the stage PCI in multivessel CAD. This is the slide which we showed that patient from the data by our New York State, that patients who get a culprit vessel PCI versus multivessel PCI, as you can see here, that the issue always comes that should you just do a culprit vessel PCI versus multivessel PCI, that multivessel PCI is associated with higher event rate, but definitely on the long run is associated with that if you do a stage intervention, that is the green bar, associated with a lower event rate compared to you leave them alone. So, multivessel disease you do only culprit. If you do a PCI in hospital, don't do well, but if you do it later on, do well, and don't leave them undone. And this is where we knew the data already, and then the latest data which just came out from the Horizons AMI, which is the stage versus one-time PCI. You can see here that stage PCI versus one-time PCI, that one-time PCI of a multivessel in acute MI was associated with a higher event rate of the mortality, reinfarction, stent thrombosis, and MACE compared to you do a stage PCI. And then there is the meta-analysis also in the same month by taking the 18 studies of the 4 prospective, 14 retrospective trial showing the same message. If you combine culprit vessel versus multivessel PCI, culprit vessel wins. If you combine culprit vessel only PCI versus stage PCI of the multivessel, your stage PCI wins. If you go with a multivessel PCI done in hospital versus stage PCI, again the stage PCI of the multivessel disease wins. Short term data, similar data exactly on the long term mortality. Basically it seems to be that the right approach for these patients are the PCI of the non-culprit lesion during STEMI PCI is not routinely recommended, because if you need to do the PCI of the non-culprit in multivessel disease should be delayed. Now, there was editorial 2 years ago from one of the European heart journal, reason being that many times you had to do it because of financial reason, because otherwise patient had to pay out of pocket again. At some center they do financial burden and also patient compliance. You have 95% lesion and you feel that you cannot leave this patient alone. Patient may not come back for treatment, particularly patient does not have insurance, so they may not be able to come back. In some cases could be done, and that's a nice editorial by Bittel in this Jack, these 2 papers, showing that maybe in those cases FFR will be the key, that if your FFR shows the less than 0.8, those patients have a risk for high event rate, and after your successful PCI of the culprit, you may get to the non-culprit. But so far, based on the ACC guideline, non-culprit lesion PCI at the time of STEMI in a hemodynamically stable patient is class 3 indication that could be harmful. Now then, second issue comes, what about the data in the acute coronary syndrome? This is from the ACC-NCDR data. Stage PCI versus one-step PCI basically showed that if your one lesion did good, not in STEMI patient, but in acute coronary syndrome patient, that you can go ahead and do the second lesion, but they did not compare this with the stage. So this does not answer the question, should the stage be done out of the hospital, and that's where this trial does not answer. But basically it shows that if you're in acute coronary syndrome, your one lesion is good, you can go ahead and do the second and third lesion if necessary. What about elective patient? This is the data from Israel, stage group versus one-step group. You can see here that one-step group had a higher MACE rate, higher the in-hospital death and MI, the non-statistically, but trend. In hospital 30 days and 1 year. So there seems to be that stage intervention is a preferred approach in many of these multivessel CAD once you decide. Now, how do we put it together? The one stage versus multivessel. One is, the goal should be that multivessel PCI strategy is all PCI should be done at one step, unless there is a reason to stage it. Because patient goes well, stable patient, you did one vessel, looks good, you go to second vessel and third vessel, fine. Which patient would you do the stage? Old patient, patient with heart failure, severe LV dysfunction, renal insufficiency, and any procedural complication. Then don't do the second vessel. High contrast load. Some people say go to the double, once you go to the 3 digits, although in the literature it's a 5 ml per kilogram, you go beyond, then yes. If you do ad hoc PCI, and you have multi lesions. So do the simple lesion, bring patient for the complex lesion, and particularly true for the CTO. CTO as the stage intervention is the preferred approach, not at one point, and of course the long procedure time and patient fatigue. Biggest question comes to the appropriateness, that what you do in these patients, that where should be appropriateness criteria. Clearly but the literature is not very clear, but I am making this statement that appropriateness use criteria should be applied at first PCI and carried for stage PCI. Why? Because all our trials which we had done, like Freedom and Syntax and so, all required that stage PCI was decided at time 0, and they went ahead and did the PCI in the stage form. With that note, I would go, Annu is ready actually here to do the intervention, and we can come back to the angiogram.
Burr actually in the guide. I think what would be a technical challenge in this particular case, we are starting that once we selected 175 Burr as we had decided that we are going to do. Now once as you are coming out of the guide, if you see here the vessel, it is a nice takeoff of the RCA. The problem would be that if you have upward takeoff of the RCA, anterior takeoff of the RCA, that this is where you will face a problem in getting the burr into the vessel. So usually it should be a one person technique where the same person is
picture in the picture with the hands on this side, because that always, yeah, hands, put it in the picture, both.
So what I am doing is I am advancing the burr, at the same time a little tug on the wire, so that I know the burr is going in very easy. Now as this is happening, what I would think is going to happen is that the guide will start backing off, and this is what is happening. In that situation, I think try not to do anything further.
Yep.
Do your 3 steps at this particular stage, which would be that you have released the knob, backward forward, take the tension of the Teflon sheath and the burr, the movement of the burr. These 3 steps, sometimes the burr will go forward. At this time I think we are in the right position. If with this 3 steps we still think the burr is still in the proximal RCA and movement of the burr or trying to get the burr further, the guide is kicking off. At that situation we got to think of doing it by doing the Dynaglide. So right now I think we just start the rotational atherectomy. I am just going to tap on the Dyna. There was no movement of the burr, and just start. The ACT is 350 with angiomax. Slow pecking motion, go forward, pull back.
Pacemaker on.
Forward and pull back.
Pacemaker at 60.
So I think what has happened is we have been able to do the lesion at one go. Pull back and wait.
Annu, that's an excellent demonstration, and several people had asked us exactly to demonstrate those precise movements. Now clearly you are going to proceed with the single burst strategy here, no?
Yeah, now that's what we want to do, but I think what I am predicting is that when we are reaching the distal RCA, this burr might give us a trouble, since it took me at least 5 passes to get into the lumen, to that what we call the true lumen, through the stent studs into the PDA. Now the question comes is, we do one more run here with the rota, and then how do we get the burr to the distal RCA? We have to do Dynaglide and get the burr there. So this is a smooth pass. So what we do is go back on the Dynaglide, and here you are going to tighten the knob.
Good. Okay, let's advance. Press the brake, release.
Brake release, so that this particular wire is released off the brake, and then I am advancing it slowly, manual. The guide will come back.
Yeah, and that should be good enough.
Yeah.
Good.
So now what I did is I advanced the guide, and we saw some movement in the burr. So now we are in the distal RCA.
Good. Okay.
Come off Dyna and start rota again. At this time you don't have to do the 3 steps again. So here, this is where we know we may have trouble always. You have to make sure you are doing nice rotational atherectomy and try not to push the burr, because this is the place where you may have burr entrapment. They said 20 seconds, so just pull back and wait. For some reason the patient, you give atropine, it's pacemaker dependent as soon as we go on do the rotational atherectomy. Maybe a little bit more.
Go.
We try one more pass. It is still giving us a hard time. We may have to downgrade.
Downsize to 1.5.
Because we don't know whether it has been a kissing balloon done after that. That's the whole issue. It looks like they had done it. There you have crossed it, part of it.
Part of it?
Yeah.
Just take it out.
Yeah.
Don't do one more.
Yeah, okay.
So I'm just trying to see if the burr is going to make a progression on its own. Pushing is an absolute no-no here. When you're done?
Yeah.
Just the ostium we took care.
They were supposed to do ostium anyway. Yeah. We need both wires.
Yeah. So coming out would be very easy. I just have opened the Y connector. I am coming out with the burr.
And the press the brake and advance.
Advance. The assistant presses the brake and advances.
And if the single person doing it, there is also a system, because not everywhere you have the assistant. Sharma has the assistant available. So that what you do is you can bring this and basically fix it. So then one person can remove it. Now your burr has been stuck. The clip has inserted and the brake is already pressed. So now you do a one-man procedure. So this actually has been advocated also.
See, other thing also happens while you are waiting. We had the rotor drip on, which can cause make like a big pool. So just when you are cleaning the rotor wire, very important that you will make 3 loops, go underneath the tubing and keep it on the side.
Anu, maybe in one of the archive cases we could also prepare a slide as to your components of your rotor drip.
Yes. So once we do always before you wire, we take a picture.
Yeah, we need a little better. 1 second. There was a lot of flush in there.
Samin, a quick question has come that you personally, are you using the Oasis 7 regimen?
No, absolutely no. Because remember Oasis 7 again, there was a higher Oasis bleeding, current bleeding compared to a little bit of TIMI higher bleeding. So if we use 150 milligram, that will be guided by platelet inhibition testing. So that any time we use a 150 milligram, it will be guided by our Acumetrics having the platelet reactive unit of more than 230. So that in Mount Sinai we do not use, I make it a very clear statement, we do not use the Oasis strategy of 1 week or 1 month, because clearly the Oasis was only 1 week, 150 milligram. But the problem is very tough to write a prescription of and confusing to the patient. So many of the interventionists have adopted the practice that give it for 1 month and so, which is no harm in it, although that was not tested. But even with a 1 week, there was a little higher bleeding. So that clearly that which case will develop bleeding? Those who are the already effective Clopidogrel and you are increasing the dose. Because there is a one paper actually shows that if your PRU unit is less than 180, you are hyper responder and then you may have higher bleeding. So therefore, having the same issue that we try not to use 150 blindly, and the cases will use it only if there is a PRU unit of more than 230 on Acumetrics testing.
Samin, there is a question by Dr. Costa Nicoletinos, sorry to struggle with his name. How do you or when do you refer instant restenosis DES for cabbage?
Yeah, it's the same. They will go through the same patient with the syntax, and I would say all the patients have multiple restenosis. Matter of fact, at present, this week, one patient had a surgery last Friday, one patient having surgery today. Those were the diffuse restenosis.
Distal balloon 2.5.
Yeah,
2.5.
yeah. The diffuse instant restenosis. One patient actually was Clopidogrel non-responder, was also prasugrel non-responder. Came back with the third small, the third small MI, and that patient went for surgery. But I would say same. The extensive disease and multiple failure. Just bought patient come back once or twice, and still your syntax score is less than 25-30. Clearly the 33 is the cutoff, but that patient will still try to do a PCI, the second PCI, rather than sending the patient for surgery. We can take the rotawire out now. We don't need it. Yeah.
So the rotawire will take it out. Otherwise, we'll be having 3 wires in the vessel.
So you have a high
So we have one. We have a run through which went easy into the PDA, and I have a fielder that the same fielder that we used initially into the AV continuation RPL, and we have a 2.5 15
What?
track balloon
Track.
in the PDA.
A few millimeters
Yes.
inside.
Yeah.
I think the PDA has a little more disease.
Good. Here.
Yeah.
Don't. Mean
Yeah. And
just a balloon.
yeah.
I think the goal would be to have a good balloon result at that area.
So, I mean, you kind of mentioned about that as an important criteria, but practically, do you think there is going to be a big issue about
That we
the
have a 3 or 3.5.
Yeah.
BID dosing with the Ticagrelor?
And I think that's one of the issue, and
Go up here.
the compliance point of view, and so is. Yeah, let's just start putting. We can do a bifurcation there. Yeah.
No.
Or you need another 2.5, 20 high pressure.
Yeah.
Good. Okay.
2.5.
Good.
That is a 2.5
Yeah.
in the.
No, I think that will be a issue. Now, question is that how much it is the issue, because I say it's not much issue because our cardiac patients are taught to take medicines twice a day. Most of them take the medicine in the morning.
2.5 balloon.
That they use the medicines in their pill box. The problem is that it is recommended that the both is actually for both prasugrel as well as for the Ticagrelor, that they should not come out from their original box. So that I don't know whether you can although patients put medicines in their pill box, so that it is not recommended to take it out from the box. That's the only issue. But yes, to me, I think it will be some issue. Whether it will be a major issue, because we know the people do skip the doses all the time, and we also know that skipping the dose is not going to be associated with any high penalty.
So we have a balloon which is a 2.5 into the 2.520 we have in the AV continuation RPL, and then the same balloon which we had in the PDA, we are just doing a kissing balloon dilatation. Both we have gone at 12 atmospheres.
All right.
Yeah, I think the RPL we need to open the distal edge of the stent. There is a 90% lesion in the RPL at the distal edge of the stent. So let's take the PDA balloon out. PDA balloon is good. We can take that out. This is the one.
So, I mean, you also mentioned during ad hoc PCI of staged lesions, some people would argue that it may be a better strategy when you have complex cases to first do the more complex lesion, because just in case that fails, you still have an option for surgery, whereas you could do a simple lesion, do a procedure, then fail later with the complex one, and that may not be the best solution.
Yeah. Well, that's a very good point. No, your wire is in, look at this, wire of the AV. Okay, little distal. Okay. Yeah, the very good point. The question comes is, what I made in that particular case, and that is our practice pattern. Reason is that complex will require additional amount of time, additional amount of dye. If you are questionable, then question is very simple, that you have a total occlusion, and you think that if you cannot open the total occlusion and patient will go for surgery, then yes. Because, and by and large, that now what is the incidence of a patient going for a PC cabbage or even elective cabbage because your PCI failed acutely time period, not the restenosis. I would say, I don't know any case we have. So that's extremely, extremely rare, and this actually from the logistics point of view, it is better. You want to dilate the mid lesion at least? Yeah, once, go. Yeah, from the logistics point of view, it is better just because of that you have a less procedure time and less additional contrast volume. So that's why basically I said, and this is what we practice at present. Now this is the 20 atmosphere for the mid. See that lesion? It was said non-calcific, although it has not expanded despite this small balloon. It's although a small balloon. but has not expanded.
Anu, at some stage if we can do an angio run to see.
Yeah, we are going to do it now. Take everything out.
Samin, another very good question has come that should it be a routine strategy to use different DES with the DES instant restenosis?
Yeah, very good point. Actually, there was some anecdotal non-randomized trial, but now there have been 2 trials which have answered this question, whether should be the same stent, the coating versus different, and answer is no different. Yeah, yeah. So let's to the wire and we take a picture. Though basically that yes, we do routinely this strategy, but it is not based on any randomized data to show that this strategy is better than homo stent approach versus hetero stent approach. Yep. We can just put a stent directly.
Are you happy at the bifurcation, how it looks?
Bifurcation looks very good. I think one of the interesting point that we have to make is when we are doing this bifurcation intervention, kissing balloon, got to pay attention to the distal, the wire in which part of the distal vessel it is. Many times what happens is it could have gone when you are doing this multiple movements into a small branch, and then if you dilate the vessel thinking of the proximal area, that you may end up with a perforation since the balloon is now opening into a small capillary. So, it is very important when you are doing the distal vessel intervention, pay attention to where the tip of the wire is and where your balloon or the stent is going to be placed.
Yeah, then what we will do is now strategy wise, now knowing that we are getting to the time, that we will put a stent in the PDA. And we, as I said, that we do not know whether it was a bare metal or paclitaxel or so, and then we put a stent in the mid RCA. So, that will be our goal. So, now we are going to the PDA with a 2.75/28 because we need to cover that moderate disease, and then prox with the, we want 3.5 or 4.0 in the RCA.
Yeah, 4.0.
4.023.
Yeah, 4.0 sounded.
Yeah.
Samin, to me, one of the understandings of this case is the maturity to, after all, how many distal lesions do you chase, how many small branches do you fix, and therein I think lies the wisdom to do exactly what may be appropriate here. This is what stent do you have there?
This is the 2.75/28 XIENCE.
Okay.
Deep breath, sir.
It takes a little time sometimes to go through, although we are dilated that area quite a bit. Now, if there is you need the buddy wire, you have the wire there already, you put into the PDA, give you additional help. But I think we need to go a little bit more.
Deep breath.
And you have always stopped worrying about jailing this wire there.
Wires, yeah.
Okay, unless even
in
for
this
hydrophilic
situation,
wires.
I think jailing a wire is not recommended since you have multiple stents.
Yeah, because the stents, yes.
Yeah. I think you are good.
Huh? No, but then we have to go through it and dilate that.
Should have gone with the shorter stent.
No, but there is a disease up to mid. Yeah. If need to be, we can go with the 23, 2.75/23. I don't think we should put another layer. I would just go to the ostium of the PDA.
This is not going to make a tough.
Okay.
Yeah.
2.75/23 XIENCE will be okay.
2.5.
Huh?
So, Samin, tell me,
2.5/23.
how does it happen? You just you're going to exchange it for a 275/23?
Yeah. Yeah.
So what happens? Who's charged for?
Yeah, that's a very interesting actually, and we have to be thankful to all these device manufacturers and stent manufacturers, because this one will be they will return it as a no cost.
Excellent.
And
so
that's very important, because otherwise it will be a major issue, and that actually the issue outside the country where the patients are paying out of their pocket, and that actually turns out to be one of the reason in many of these cases. That you do a multi-vessel PCI, because every time they come, the additional charges need to be done.
Yet it has to be done in a responsible fashion, because I can tell you it's there are no free lunches. Nobody gets anything for. So that stent is out, and hopefully the patient is not billed for it.
Right, absolutely. And this actually will write it in our report the stent did not cross.
How often are you doing this? 1 to 2% of the cases, 5% of the cases?
No, overall, I mean, we used about 600 DES per month. How many return no cross we sent? 10, 15, 20? About 15, 20. So the 20 were the basically 3%.
3%, all
3%.
right.
And that's a very good.
You have never needed a calculator in your life, I can see. Yeah, that makes sense, I think.
Yeah. Yeah.
So this is a 275 23.
23, yeah. Yeah, that's fine.
Because you don't want to put in too much layered stents there.
That's exactly correct. Good.
So now what the thing changed was same, the length was different, the size of the stent was different, and more important also what happened is, if you see, I took the fielder wire from the AV continuation and went to the PDA.
Which are the wire we did not.
So I went on the fielder wire. So before you deploy your other wire, you cannot trap that, and this is very common that when you are pulling your second wire, if you see what has happened, the stent got pushed forward because of the inertia that is maintained in the vessel since we are trying to get forward. The other important point that we need to make in this kind of bifurcation, and you are trying to put the already 2 or 3 layer of stent, that we are trying to get our third stent in, that as operator you need to be paying attention that situation can happen that this stent can start stripping off there. So you got to be very careful how much push pull technique that you are doing, and be aware that there could be a stent that could be stripping off in this kind of situation.
With the XIENCE stent, the stent is exactly at the marker.
Yep, exactly. So we are going to pull back 1 second.
Wait.
Yeah, good. Go on.
No, it is still, I think it is half a millimeter inside.
Yeah, at the marker. That's the key. Yeah, you can go clearly that you don't go beyond 12 atmosphere. So that, and 2 dilatation, and then second one more spherical expansion. The proximal area has not fully expanded. So this now we can bring back and go to a little high pressure because you already have a stent in the distal RCA. Good. So now we can go 20 atmosphere here.
You are protected within the confines of the stents.
Right, exactly. So there is no need to bring back a high pressure balloon dilatation, although there is one trial did say that taking a 20 atmosphere of the compliant balloon versus non-compliant gives you a different lumen based on the IVUS and maybe a trend towards lower restenosis. But if you are angiographically and your stent boost, things look good. To me, I think it's a fully expanded, and that's completely fine.
More questions from the audience. Do you have both the Volcano and the Boston Scientific IVUS, and where are you using those individually?
Yeah, I mean, I think one of the advantage of the Volcano being the for virtual histology point of view, but from our point of view, very simple. We have 6 cath labs. One of them is with the pediatrics. So the other 5 labs we have fixed system. In 3 rooms we have the iLab, and 2 rooms we have Volcano, and the both rotational as well as the old device available for Volcano. And basically, you want to take a picture before we put a stent in the mid now. And
the 28, 3.5?
Yeah, 3.5, 4.0. Yeah, let's take a picture. Yeah, therefore, and then we have mobile unit which can go to any other rooms which we use sometimes, and so I think we just put a stent in the mid and then we are done, and rest we can just finish up with some post dilatation.
Anu, what was the vessel size by IVUS?
Was a 4.0 in the mid RCA.
Yeah. And that was the question I also ask, that do we size the stent to taking to the media or external elastic membrane? That will be a little too much. We usually do it if you're deciding with the IVUS, cut down by 0.5 because those the media to media what we used to do in the past. That it's always the associated with the that you see step up and step down. Ready?
Yeah.
Anu, the length is 18.
This is
this is 20,
4023.
4023.
XIENCE?
Yes.
Yeah. Could I use 28 also? Yep. Yeah, and then with this we need to post dilate with a 4020 high pressure balloon.
You think the distal part is overlapping?
This is the calcium. Yeah, although this distal part, again, the area which you did not do a balloon, even if you did a rota, is okay not to put a stent there. But definitely this is the calcium. clearly one more, clearly showing that it's not fully expanded that area, because we saw that circular calcium ring.
So, based on what you mentioned today, and of course, what would be the long term antiplatelet strategy for this patient?
Yeah, this I mean, I think the data basically support at this time until we have the other the depth study data that should you be giving even with this second generation stent for 3 years and so. But our basically our own experience and so our present recommendation giving for 12 to 15 months. Only 12 to 15 months, yes. So this patient will get, now question is that do you use 81 milligram or 162? I would say if the many times when we have multiple stents and overlapping stents, we do use 162 milligram of the aspirin. We also know that active ingredient absorbed body is only 40 milligram, but some patients have variability, so that to take that issue out of the equation, we do go with the go with the 162 many of these patients, but otherwise routinely in our cath lab it's 81 milligram 16.
Thallium stress test at 6 months?
Yeah, that 81 milligram is the standard, and now with the Ticagrelor actually it becomes more important. Now question is which patient you are going to switch. The issue comes is that which patient you are going to switch or start Ticagrelor at present. I would say this goes to a little beyond just the drug effect, and so one is the availability, one will be the cost, because I have not been told clearly that it will not be a higher cost to the patient. Part of the little adoption issues with the prasugrel was that it was not available, at many centers when it came into the market. But although we have been promised by AstraZeneca folks and that all the pharmacies carry the drug now, and so that it's less of an issue. And then of course the cost, because many patients after a few months, many patients after a few months of prasugrel and they still have to pay $35 from their pocket, they say why don't we change it to a Plavix, Clopidogrel, and that actually, as I said, will become even bigger issue in a coming time when it become more of a generic. So that I think this all issues will play in slowly, but to me one place where it will be very good is the management of patients with acute coronary syndrome before we know the coronary anatomy. So that to me is a very big for the drug. Now we also know that once you have the rapid onset, that you give maintenance, then it takes 5 days to work. I mean 5 days to wean off. But if you have just given a loading dose, that how quickly you can wean off is totally the different issue. I think we can take everything out and take a last picture.
Did you notice there was a little waste? It took a while to go in the very proximal segment?
Absolutely, absolutely. And this is, I would say that what also rotation atherectomy requires, that you don't have to go to those crazy pressures and worry about the stent expansion and so. So that this is with a combination of the rotablation and high pressure balloon, we got this results which are just coming up here. I know we are about 5-10 minutes over, but if everything is good, we stop here. The goal was that keep one of the good branch. You want to go other?
Yeah, little AP cranial maybe. Here we go. The distal branch bifurcation looks all right.
Right.
Samin, what is your take home message today?
Good. The basically same, that issues on the newer antiplatelet therapy and stage PCI. The Ticagrelor is a new addition to our available antiplatelet therapy armamentarium and will allow us tailor-made depth, and tailor-made that patient has to be compliant because has to take twice a day drug, and secondly that patients where coronary anatomy is not known, this will be a good agent to use. Second, the anticoagulants added to a depth seem in the trials seems to be associated with increased bleeding with added borderline or no ischemic benefit. So that I think the trials of oral anticoagulants newer will go away. Because there's a lot of particularly with the latest APPRAISE-2 trial showing no benefit. Third, stage PCI is an acceptable strategy in selected cases for multivessel CAD. It is an approved strategy in multivessel disease after primary PCI. That basically with the primary PCI should not do it at the time. Very important that the primary PCI should not do a multivessel disease PCI. It should be staged. So that's what we basically learned. And some selected cases, you for the multivessel disease, even elective patients should come back because that way you seems to have little better outcome on long run. With that note, I will just ask Anu to make a final comment and we conclude our today's webcast. Anu?
Anu, your final thoughts on the case?
Yeah, the case is an angiogram. Yep.
I think what like we mentioned here important was how would you tackle, I mean if you have multiple branches and distal vessel, I think just focus on one of the branch. That's what we did, we focused on the PDA, we have a nice result of the PDA and just a nice balloon result of the RV branch, everything is okay. And one other point that we want to make is that there is a type A dissection in the mid RCA. If angiographically you can actually appreciate that.
Show quickly, yeah, that's important. Yeah.
And this is a kind of dissection that you can leave safely. If you can appreciate in the angiogram that
based on the large size of the vessel and distal flow?
Distal flow, exactly. Okay. I think when it is from C onwards, when it is like a cap and then there is a dye staining, that's the time I think you got to worry that whether you have to put more stents or no. But in this kind of situation with the good antiplatelet therapy that this patient is on, this kind of dissection could be safely left alone.
Okay.
Samin, excellent coverage. Congratulations to your fellows helping you, your staff. We come to the conclusion of another case which you can archive. Hopefully you will find it useful. Please let your feedback keep coming. It contributes a great deal in our quality improvement. We will see you next time, session 27 on September the 19th. Goodbye.